Mandibular fractures. Mandibular fractures is one of the common fractures which can occur in the oral cavity or in the facial region. And theoretically, this is very important even for undergraduates and postgraduates, and it's most commonly asked as an essay or either an essay or a short note. Now, before I go into in detail about the mandibular fractures, when you write for an exam, it's always better to have a flow chart. You should know what you are going to write. Have an introduction. The following headings is often essential or useful for you to remember what to write for an essay. Modify it whether it is an essay or a short note. For example, like you write for an introduction, following which you can history, either you can combine both etiology, prevalence, or incidence if possible, and then classification. Classification is a common factor for most of the diseases or most of the questions, and write at least 2 or 3 classifications. It is not possible to memorize and write all the classifications for your exam, but at least have a 1 or 2 classifications is essential. Then clinical examination and clinical features. That is the way of a diagnosis. Later, you go for the investigation. After the clinical examination and features, you go for the investigations, which radiographic or non-invasive procedures or non-invasive investigations comes under that, including your routine blood investigations. Management. Management can be either surgical or non-surgical. Now, mandible is a tubular or a tubular shaped bone bent into a horseshoe shape. It's one of the thickest bone, or the strongest bones in the body. And if you represent the skull as such, you have a matchbox which represents the maxilla, a helmet which represents the skull, and a hockey stick, the shape, mandible. So the strength is also compared to that. The skull is compared to like a helmet, whereas maxilla is very thin like a matchbox and you can crumble into pieces, and mandible is as sturdy as a hockey stick. The treatment of mandibular fractures is even dated even the 16th or before Christ. It was actually, though we don't have clear evidence, we have some evidences from the mummies which has been described in the Egypt and the Egyptian scrolls and scriptures or whatever has been written into the caves. The treatment of mandibular fractures or the diagrams was even evident even during those times. But the concept of immobilization was actually introduced by the Hippocrates, and later evolution or treatment of mandibular fractures during the First World War and Second War, the need of fixation of fractures came into existence, and people tried bandages, covering, stabilization, or the stabilization and the union. Union used to take place after a process of stabilization. Later, the need of reduction and fixation came into practice. Initially, it was only immobilization, holding the pieces together, either using a bandage, crepe bandage, tying together with wires, etc. So the concept of open reduction was initially came into practice only in the 18th century, or it was documented in the 18th century. We don't know whether it was practiced even in the 16th or before Christ or in the earlier stages. And the documented open reduction came into practice in the 18th century, and later various modifications came. The use of materials starting from transosseous wires and the fixation devices. Initially, they used metal rods to fix these mandibles, to hold the pieces together. Like how you have a fractured arm, you put a roller or scale and tie it together. Similarly, fixation devices or instruments came into practice. People started inventing newer materials for these kinds of fixation. Etiology is common. Now we know the high-speed cars, motorbikes have caused a lot of road traffic accidents. And of course, road traffic accidents is one common factor. We have sports injuries, we have assaults, and so many other fall from a height, slippage. I mean, all these things can result in any of the fractures of the facial skeleton. Prevalence depends on the area, urban, city, traffic, the or the kind of practice or the kind of habit the population has got. So rugby players, where in those areas more commonly mandibular fractures are there, or in areas in, for example, in horse races, and the most common trauma is zygomatic fractures. So similarly, it varies. It cannot be a steady one in one particular place. Where the traffic is more, where the heavy vehicle is there, or when the rules and regulations are a little bit relaxed, road traffic accidents are more common. Now, distribution of the fracture, it depends on the kind of trauma, of course, but we know because of the areas of weakness and areas vulnerable to trauma, the most common fracture which occurs is either in the angle of mandible or in the symphyseal or parasymphyseal region. The body fractures are the second most or the third most compared to the angle and the symphysis. Now, ramus fractures are very less common, and the condylar fractures are nowadays because the transmission of force is through the condyles, it's a cause of indirect injury. So that can result in more commonly the condylar fractures. So condylar fractures accounts for the third or the fourth most common prevalence of it. And the least fracture is a coronoid, because coronoid fractures direct trauma is always protected. It's underneath the zygomatic arch, so it is always protected by this zygomatic arch. So less common, unless because of the heavy muscle pull and trauma, it can fracture. Next comes the classification. Classifications. Why is classification important? Classifications are important so that we know that such group of fractures, there is a particular modality of treatment. So we can treat accordingly. If you don't have a classification, randomly it is placed, for the treatment options for different areas vary. So if, for example, if it's a symphyseal fracture, we know symphyseal fractures, we have this much force and we need this much of plates. And this is the kind of fixation or kind of reduction which has to take a bit. Whereas it's a condylar fractures, this is the protocol for treatment. So in order to format a protocol, people started classifying all these fractures. So we have various classification of this. The common or the simplest one is the Kruger classification. How did he classify? He classified as a simple and a closed fracture. That is the one. Now, what do you mean by a simple fracture and a closed fracture? It doesn't mean that it is one piece or two piece. A simple fracture is one which is not communicated to the exterior. Now, what do you mean by exterior? Exterior means it can be towards the out. So there need not be an open wound. When the term exterior means, we feel that it's an open wound. Definitely, there need not be an open wound. The tooth, the fracture can definitely, or any bone can communicate even through the root or the periodontal ligamental space. Though it is not visible, there is a communication. So technically, there is a communication in all dentate areas, where the tooth bearing areas. So any fracture involving the tooth barrier is not a simple fracture. That is the most important point which we have to keep in mind. A closed fracture, or that's another term for a simple fracture. So a simple fracture can occur in non-tooth bearing areas. For example, angle of mandible beyond the third molar. That is one area. Or a fracture in an edentulous mandible, or in an edentulous area is known as simple. Now, compound fracture, the other term is open. That is, it is open into the exterior. It is not a comminuted, or it is not multiple pieces. It can be a multiple pieces or a single piece. It doesn't matter. But if it is open to the exterior, either through your periodontal ligamental space or all tooth-bearing area fractures are considered as a compound or an open fracture. And of course, if there is an open wound also, it is not considered as a compound fracture. Next is comminuted. We all know what is comminuted, multiple pieces. Whether it is involved in the dentate area or the tooth bearing or a non-tooth bearing area, it doesn't matter. It may be a symbol or a compound. Comminuted means it is multiple pieces, but need not be an open wound. If there is an open wound in a comminuted fracture, then we call it as a complicated fracture or a complex fracture. Complex fracture means the involvement of multiple structures. That is, it is the soft tissue is involved, the muscle is involved, and the bone is involved. That is what we call it as a complex fracture. We have an impact. You know what is the term impaction? Impaction means something which is embedded inside. It can be the tooth, impacted tooth. Wisdom tooths are impacted. Sometimes you call it. So impacted fracture is a bone piece going inside a bone piece is known as an impacted fracture. Green stick fracture. What is green stick fracture? What do you mean by green stick fracture? It's a thin fracture line which is usually clinically not very visible. Maybe you can detect it in a radiograph and there is no displacement of the fragments. And where does this occur? Does it occur in an adult mandible? Very rarely a green stick fracture occurs in an adult mandible. It usually occurs in areas where the bone is flexible and thin. So it's like a green stick. It is, you can call it as a fracture, whereas it is not fully fractured. So it occurs mostly in a developing age or in children. Now, pathological fracture. There can be various pathological reasons for a fracture to occur. A tumor in the mandible, a cyst in the mandible, whether it's a benign or a malignant lesion. The lesion can cause erosion of the bone and destruction of the bone and make it weak and thin, and spontaneous fracture can occur. So such fractures are known as pathological fractures. So that is the basic classification. Now, having understood the basic classification, we'll move on to some other classifications. The Rowe and Killick classification. This classification is also quite simple. Not commonly practiced, but it's quite simple. There are two basic classes. He has divided it into two. One is involving the basal bone, the other is not involving the basal bone. The involving the basal bone fractures can be divided into single or unilateral. One fracture, unilateral, one side fracture, or double unilateral. Two fractures are seen in one side. Then he is classified as a bilateral fractures. Both sides, left and right side of the mandibular fractures, or multiple fractures. Left and right, one or two or three fractures had occurred. Dingman and Natwick. There are two persons, one is Dingman and Natwick, and they have classified, their classification is also quite simple depending on the area. One is, the first classification we mentioned was on the type of fracture, whether it is simple, compound, compound. Second is also more related to the occurrence of the area of fracture, whether it's unilateral or bilateral. Now the third one is on the location of the mandible. The mandible as such is, if you remember the anatomy of the mandible or the mandibular part, we have different areas. So as you can see in the diagram, one is a midline. Midline fracture is also known as the symphyseal area or the symphyseal fracture. We have the bone component and then we have the alveolar process on the top of it. Now, symphysis, if you go beyond the symphysis, we call it as the parasymphyseal area. And then beyond that, we have the body. The Mendel foramen, or beyond the Mendel foramen area is the body up to the molars. And beyond the body comes the ankle. And then comes the ramus. Ramus, as you can see in the area, is extending up to the subcondylar region, excluding the coronoid or the coronoid notch. So that is the area of the ramus. Below that comes the ankle. Forwardly comes the body, parasymphysis and the symphysis. And of course, on top of it, we have the dento-alveolar or the alveolar process with the teeth sitting on top of it. And beyond the ramus area, we have the condylar process as well as we have the coronoid process. So fractures occurring in these areas are known as symphyseal fracture, parasymphyseal fracture, body fractures, angle fracture, condylar fractures as ramus fractures. Okay. So three classifications we have finished. We have the fourth classification. It's very easy to remember all these classifications if you Look at the diagram and memorize the diagram in your mind. The Kasanjian classification. He has classified it as very simple. Only 3 classifications. No complications at all. Class 1, 2, and 3. Class 1 is the teeth are present. It is according to the presence and absence of teeth. That is the basis of Kasanjian's classification. So class 1 teeth are present on both sides of the fracture line. Class 2 teeth is present only on one side of the fracture line. Class 3 patient is completely edentulous. Now, why did he classify it like this? Maybe there is some significance in non-surgical management of these kinds of cases where alveolar wirings or dentoalveolar or arch bar fixations were most commonly employed. In those times, the teeth had a lot of importance in maintaining these fractures. You want to reduce this fracture, you need teeth on both sides. It's quite easy. You simple wiring or interdental wiring or what we call as the bridal wiring can be done. So it's as simple as that. Suppose there is no teeth on one side. These kinds of wiring is not feasible. You will have to find an external source to pull the other component, edentulous area into this, and a completely edentulous mandible. The treatment options are less. So maybe that is the reason behind for his classifications. But with the invention of the modern techniques, with newer fixation materials, newer surgical options, and plates, mini plates, compression plates, well, this kind of classification is not commonly useful now. We have a third classification or a fourth. This is a fourth classification, but it's based on the anatomical structure. The anatomical structure, the muscles attached. These muscles are very important. You know, there are a lot of muscles attached to the mandible. It pulls in all directions. It opens, closes, lateral movements. So any fracture in between these muscles can pull away these segments and makes a reduction difficult. So the classification was introduced as favorable and unfavorable. Now these favorable and unfavorable are in different directions. Like I said, the mandible can be opened, closed, it can move to the sides. So depending on the movement, this is classified as a horizontally favorable fracture and another one is an horizontally unfavorable fracture. As you can see in the diagram, horizontally unfavorable. For example, what do you mean by horizontally and what do you mean by vertically? Horizontally means you look at the mandible in a horizontal direction, as you can see in this diagram, and the fractures are displaced or it is not self-reduced, it is known as an unfavorable. The second diagram shows the same line of fracture in a different direction, but you can see a self-reduction because of the muscle pull. You see the medial pterygoid is pulling towards inside and is holding the fragment into the anterior undisplaced area. So this is called as an favorable fracture. So that is regarding the horizontally unfavorable and horizontal. Now vertical, you look at the patient from in the front view, and if it is moving up and down, it is called as a vertical region. So vertically, similar lines, one line extending from the distal to the mesial aspect towards the lower mandible, the masseter is pulling up and will hold the fragment in position, and that is called as the vertically favorable fracture. Whereas if it is in the opposite direction, the masseter will pull it forward and upward. That will result in an unfavorable area because it is totally displaced. Now you have to pull it back and hold it in position. Again, there is a the muscle pull is actually present there. Whereas in the first diagram, as you can see, vertically favorable fracture, the muscle pull is in a favorable direction. It is holding it into position. You don't have to reposition it. You just have to fix it, or minor adjustments has to be done. That is called as a vertically favorable, and the other one is known as a vertically unfavorable fracture. The modern AO classification is totally given. It's given in the website. Now AO courses are present throughout the state. It's quite useful to understand the principles of fixation. And then we have the after the AO classification, having understood the classifications. Now what is the next step? The next one is to clinical feature. Look at the diagram.